as Executive Director, I'm happy to welcome you to the Rudman Center at the UNH Franklin Pierce School of Law. Also, this event is being recorded not only on Zoom, but it's being covered by the press as a public forum. So we do have our lovely photographer, Allegra, here today, and we are very happy to welcome Concord TV as well. Thank you very much to them. For those joining us for the first time, I'd like to share some information about our namesake. The Rudman Center is named for Senator Warren Rudman, a Republican who was widely admired for his integrity and willingness to work across the aisle to advance the public interest. He was a strong advocate for a balanced budget, but he also supported spending on critical programs, such as legal services. We build on Senator Rudman's legacy by providing financial and experiential support to students pursuing public service, and we serve as a hub for public discourse around the pressing issues facing our democracy. Today's event is also funded by the Peter G. Peterson Foundation, which was established in 2008 to raise awareness of America's long-term fiscal challenges and promote solutions to ensure a better economic future. Like Senator Rudman, Peter G. Peterson was committed to public service. Shortly before his passing, he is quoted as saying, "True business patriots need to advocate for their country as well as their company." If there's one theme I hope we can all take from today, it's that the fiscal challenges facing our country aren't just faraway numbers on a spreadsheet. There's our individual, personal impacts. Rudman and Peterson understood that connection, and I hope our panel today can help you each draw similar connections between national policy, the current state budget debate, skyrocketing health insurance costs in your local school budget, the price of your aging parent's hearing aid, or that unexpected hospital bill that can change everything. And now, before I get any more melodramatic, I am happy to introduce our experts and moderator. First, we are so honored to be joined by Noam Levy, who is senior correspondent with KFF Health News. Noam has reported on healthcare issues from more than 36 states and 4 continents, and won numerous honors, including 2 prestigious NIHCM awards, one for the 2019 series Inside America's High Deductible Revolution, and one for the 2022 series Diagnosis Debt. In 2015, the New Hampshire Endowment for Health funded a solutions journalism workshop for our New Hampshire Press Corps in particular, and Noam came to New Hampshire to participate on the panel, so we are so happy to have you back in the Granite State. We are also joined by our own health and life sciences law professor, Lucy Hodder. I know that many of her students are in the audience today, so shout out to the health and life sciences law students. Lucy is an experienced New Hampshire healthcare and regulatory attorney in practice for over 30 years. She founded the Health Law and Policy programs at the University of New Hampshire, Institute for Health Policy and Practice, and here at the law school. She also previously served as legal counsel and senior health policy advisor to New Hampshire Governor Maggie Hassan. And our moderator is Laura Canoy. Her name perhaps speaks for itself. She's one of New Hampshire's most well-known journalists. She was founding host of New Hampshire Public Radio's The Exchange, which for 25 years was the state's most widely recognized and respected radio program. In mid-2021, Laura stepped down from the host chair, but her skills in interviewing, moderating, and public speaking are frequently called upon. In 2022, we snapped her up, and she joined the Rudman Center as our Director of Community Engagement. Thank you, Laura.
Thank you, Anna, very much for that introduction. And welcome, everyone. It is great to see so many of you here tonight, especially to see so many students. So thank you, everyone, for showing up. Well, tonight's topic, healthcare costs and their impact on our country, could not be more timely or important. At the federal level, economists have long worried that ever-increasing shares of the federal budget taken up by healthcare programs are unsustainable, that they are leading to dangerous levels of government debt that threaten our economy and our well-being. But at the same time, many Americans struggle with their own healthcare debt, suffering physically and economically and emotionally because of it. And we'll hear some incredible stories from Noam in just a few minutes. So this evening, we are making the connection between these 2 twin problems, and we will seek possible solutions. We are so fortunate to have Lucy Hodder and Noam Levy, both of whom, as Anna said, have examined our healthcare system for many, many years. We will also be taking your questions in about 20 minutes, so just raise your hand, and Anna will come around with the microphone for both audio purposes and sanitary purposes. Let Anna hold on to the microphone, please, and thank you for your understanding there. If you are joining us by Zoom, welcome to you as well. You can put your questions in the Q&A function at the bottom of the screen. So lots to talk about. I'll kick it off, but then again, we do want to hear from you. Noam, this concern over federal health care spending, not new. People have been talking about it for a long time. How long have policymakers been saying, Medicare, Medicaid, other federal health care costs are problematic? And how do you hear that discussion evolving?
Well, thanks for the question, and thank you very much for having me. So they've been talking about this basically since President Johnson signed Medicare and Medicaid into law.
Oh, wow.
I mean, if you go back and you look actually, right after, this is not terribly well known, but right after Johnson signed the legislation in 1965 creating Medicare and Medicaid, he convened a special commission. It was called the Commission on Healthcare Manpower. And it was the dean of the Harvard Medical School, there was the chairman of a industrial company in Indiana, and they went out and they looked around the United States at American healthcare, and you could read it and it would be as if you were reading something that was written yesterday.
Really?
It was about insurance covered the wrong things, hospital bills were too large, costs were rising too much faster than the price of inflation. And actually they said, I'm going to mess up the line, but something to the effect of, when a boulder is perched at the top of a hill, a few strategically placed pebbles can stop it, but once it starts rolling, it's impossible to avoid the damage. And of course, it's been rolling now for 70 years almost. So you could say, I mean, how can we keep going on? But I think today, to answer your question directly, I don't think it's having the impact on federal debate because, as you can see, I don't even know what our federal debate at the moment is, but I think it's certainly changed in the way that people are thinking about how much it's costing them personally, and we can talk about that later.
For sure. So is it heartening at least, Noam, that this is not new? We've been talking about this for a while.
No.
No, okay.
I mean, I started covering healthcare in 2009. So full disclosure, I'm uniquely unqualified to do what I do. I don't have any background in studying healthcare policy, but I was covering Congress when I came to Washington for the LA Times. And after the 2008 presidential election, obviously President Obama pushed through the Affordable Care Act, and that there was an enormous, you may recall, it was an extremely divisive debate, but I think those people who worked in health policy felt that something really important had happened. And I think something really important did happen, so we can get back to sort of why I think actually there are reasons for optimism. But at that point, there was this feeling among a lot of the people that I was talking to, whether they were academics, whether they were people who worked in policy, ran hospitals, insurance companies, that there was this moment when we were finally going to do something. And I can tell you 15 years later that many of those people are very, very disheartened about where we are.
So, Lucy, picking up on what Noam said, what is our policy right now? Let's just get this on the table, because we know it's on everyone's mind. As far as you can assess, and things are changing, what is going on at this moment at the federal level regarding this issue of healthcare costs, Lucy, and how might that be felt here in New Hampshire?
So, thank you for that incredible question, and so great to see everybody, and also to be here with Noam, who, from KFF Health News, all my students, we're fans, we're huge fans. And I also just want to say that what I say today is my own opinion, but since I've now been exactly 10 years here at UNH and working with all of you in all aspects of the healthcare delivery system in so many ways, whatever I say is all that I learned from you, so we're all in this together. I will say that what's going on in Washington, and we don't really know, I mean, we heard this week they passed a continuing resolution in the House, and then they all took off, and the continuing resolution has something in it that it affects, at least we know the federally qualified health centers are helped, but we don't know what's going to happen in the budget, and the news is that there are going to be massive cuts to Medicaid. We don't really know how much. So there's a lot of uncertainty. But I will say the thing that is so important in New Hampshire is that we depend on the federal dollars in our healthcare system. We spend, the New Hampshire Insurance Department has put out some really important information about our total healthcare spending, and we spend about $13 billion a year on the healthcare system and healthcare in New Hampshire. And a large portion of that is from federal sources, for many good reasons. We can talk about it in more detail, but we have federal dollars, obviously, that pay for the insurance for 14% of us who are on Medicare, and that's growing. You know, we're an aging state, so we have more and more people who rely on federal dollars for their Medicare. And we all bought into that, right? So, you know, if we think about this bargain and what they're playing with, we bought into the Medicare program. We really rely on it. Medicare, luckily, they do cap their prices, so they do have some control over their spend. We rely on the federal government for our Medicaid program. Over 10% of our population is covered by Medicaid, and over half of our Medicaid budget is federal. And it's a huge portion of what we rely on to access affordable health care for our population. Almost 95% of us have health insurance. And, you know, affordable health insurance is how we protect ourselves from bankruptcy for the health care needs we have, because we all have them. We are all integrally connected around our need for health care and the fact that we'll need it sometime, if not yesterday, then tomorrow. So it's a risk we all share.
So what happens in Washington matters a lot
Oh,
here
absolutely.
in New Hampshire.
It is dramatic. You know, we rely on grants. The university, the Dartmouth, our Army Biofab, Department of Defense grants that were just cut the other day. So there's a lot of grant funding that really spurns our economy here in New Hampshire as well. We have subsidies and tax credits for people to get insurance on the marketplace. A vast portion of people with individual insurance have tax credits in order to get that insurance. So it really, really makes a difference. Our employer-sponsored coverage is subsidized by the federal government, and that's another huge spend. So we are really integrally involved in federal spending, and the machinations of what's going on in New Hampshire will have dramatic impacts on our system of care and our ability to afford insurance.
Well, since you alluded to Noam's work on the individual debt, so we talk about government debt and federal health spending affecting the budget, but then we have individuals who are struggling, and Noam, you've done a deep examination of medical and dental debt. Let's not forget that. How deep and how wide is this medical debt that Americans have?
So it's huge. So I mean, I don't think it probably comes as a surprise to any of you that a lot of people in America have trouble paying their medical bills, and certainly as covering healthcare in this country for 15 years, you know, you can't go into any doctor's office or hospital anywhere in America and not run into somebody who's had a bill that they have trouble with. But one of the things that I think people don't understand is how much worse it is than you may realize. So we did, as part of a project that we did with NPR called Diagnosis Debt, we did a nationwide poll to understand just how widespread healthcare debt is. And if you put it all together, if you ask people, do you have a bill that you weren't able to pay? Do you have a bill that you had to put on your credit card, that you took out some kind of a loan for, maybe a second mortgage, that you borrowed from friends or family? You put all that together, you get 40% of U.S. adults, 100 million people in this country.
That's a lot.
Have some form of healthcare debt. Yeah, it's devastating. I mean, more than half the people who have healthcare debt say they've had to make a difficult sacrifice. You know, they've had to take on a second job, they've had to change where they live, they've had to cut back on food and other essentials. 60% of people who said who have had to make a difficult sacrifice said they've cut back on food or other essentials because of a healthcare bill. So, I mean, it's just devastating. I could spend the whole evening telling you horrible stories.
Sure. I mean, you could give us one or two more stories from your reporting if you want. You know, people that you were just really struck by,
Well,
how much their lives were affected by this this medical debt.
Yeah, I think the thing that's really striking about healthcare debt in America is that if we were sitting here 15 years ago, before the passage of the Affordable Care Act, and we were talking about the burden of medical bills on people's lives, we'd be talking primarily about people who didn't have health insurance. And that, obviously, it was that lack of health insurance that drove the Affordable Care Act, that led to the expansion of Medicaid, the creation of affordable care marketplaces. But now healthcare debt in America is a problem of the insured. So most people who have debt in this country got it even though they had health insurance. And just to give you a sense of sort of what kind of people we're talking about here, this is a problem that definitely affects lower income people more. It does affect people who don't have health insurance. But it affects middle class people. Like, there was a NICU nurse that I interviewed early on in our reporting in Chicago. Allie Ward was her name. And she had been working with her husband in Dallas, and she had twins. This story stuck with me because I have twins. That they were born prematurely. They ended up in the NICU with some fairly serious health issues. And, as I'm sure all of you know, the NICU is a very expensive place. But even though they had health insurance, her husband worked in nonprofits, they ended up with $80,000 in medical bills that weren't covered for one reason or another. The boys, her two twin boys, needed a lot of therapy. They ended up having to move across the country to be closer to her family outside of Chicago. She ended up working double shifts even when the boys were infants. And I remember she said, I would lay awake at night and I would think about where could we go if we couldn't afford the rent anymore. And she said, I wanted to be a mother, I had two children, but I was afraid we were going to be homeless. And
Yeah, I can't even imagine being a mother of newborn twins, working double shifts because you can't pay your healthcare debt, and by the way, you work in healthcare.
It's barbaric.
Yeah.
It's barbaric.
Lucy, there was so much emphasis under Obamacare about getting insurance, getting everybody insured. Why isn't insurance good enough to alleviate these situations?
That's a great question, and I know I commonly say we did half the job. We got people affordable health insurance under the Affordable Care Act, and then we tried really hard to try and reduce the costs of care, and it's just complicated, and people didn't really come around the table to do it. And we often say, who's minding the store? It takes a powerful force to try and get our really big healthcare industrial complex to try and save money. And also to make sure we spend the money where we're supposed to. And that's not to say there are not a lot of really great actors, and we have a real effort to get people in insurance. And now the question is, how do we make sure, and who's responsible for making sure that we're spending it where we're supposed to spend it? We've had a long effort to try and spend it on mental health and try and get mental health parity. And, we know we need to spend it more on primary care, but we just cannot get it there. We've changed the system so much to a real infrastructure system. But I just want to take what you say a little bit to New Hampshire, because we've been really looking at what affordability means in New Hampshire, too, around healthcare. So about, not to bore you with information, but 1 in 4 households in New Hampshire with 2 working parents and a child make less than $50,000, which by the time you take taxes and housing and food, and then the average employer contribution that employees have to make is over $6,000. And then deductibles are over $3,000 on average. So while we may have, good insurance, that's not affordable for people. You aren't going to be making choices about your health care when you have that prospective debt that you might incur. I mean, how many people do you hear they don't call the ambulance because they don't want to pay the risk, And so it's really problematic when you look at New Hampshire, even though we're fairly healthy, even though we have fairly good incomes, it's still not affordable given that demographics. And, we've done surveys in New Hampshire, and, 71% of people, this is New Futures worked with Alterum, and it's posted, 71% of people said they delayed or went without needed care due to the costs. And, we're going to have to touch on prescription drug costs because that is just a huge driver of the cost increases going on in healthcare right now, and a really complicated problem to solve. And we just are not getting from the federal government the effort we need to even solve some of the low-hanging fruit around prescription drug costs.
Well, it's so interesting to hear you say that we tackled half the problem. People got coverage, but then the costs are so high that, there's the other half. And you and I have talked about this before, Lucy, and I know it's the million-dollar question, but if you could tick off like 5 or 6 factors creating this situation where everything is so expensive that the debt Noam writes about has occurred, what are the sort of main reasons we see these prices so high?
Well, I know I'm going to get a lot of input from the people in the room, but I would say, having insurance and creating affordable insurance without having that counteracting effort to control the costs of the system, and no one really taking charge of that, has really caused the cost to go up substantially. And we have wonderful innovations, but we still in this country spend twice as much on healthcare than the average developing country, and don't have the same outcomes. If you look at our outcomes, we don't live as long in just the basic fundamentals, infant mortality, maternal mortality. And so prescription drug costs are also a huge issue. We had just recently in the continuing resolution, there was an effort to bipartisan reform of the PBMs, the pharmacy benefit managers. 80% of our prescription drugs that you buy at a pharmacy are controlled by 3 prescription pharmacy benefit managers. And their ability to control and raise prices on biosimilars is incredible. 2 major FTC reports on just how much control they have and how much they've caused the price of pharmaceuticals at the pharmacies to increase to their own benefit because they own the chain of command. And there were bipartisan efforts just to make their contracts transparent that keep getting left out of every federal bill. So, there are real issues with prescription drug costs that we could go into. I have lots of examples, but I won't dwell on it. And you can just look at, I'm just going to give this one example.
Sure.
Humira.
Yes.
Which is a really
good
important
case
drug.
study.
It's one of the drugs we spend in our public, thank you, prescription Drug Affordability Board for this information that's made so apparent to us. That's one of the drugs we spend the most in our public health plan on. And it's very expensive. It's really good. They've had patent protection and no competition for a long time. And then just when biosimilars, which are lower cost generic drugs, were coming on the market, they figured out a way to manipulate their rebates and their arrangements with those 3 big PBMs so that they kept those low cost. I mean, we're talking about 6% of the cost. That's how much cheaper the biosimilars were. They kept them out of the formularies and out of the market with their rebates and their controls. So there's a lot that consumers don't see, and when you go as a patient to the pharmacy, you don't get the benefit of those rebates. You don't have any idea why your drug doesn't show up, or why it might show up 3 times the cost today, or you got to go get it somewhere else. I mean, just absolutely no idea, and we have a very hard time. We're trying on the state level to get our arms around it, but then there's backlash. There's legislation in New Hampshire right now to get rid of the Prescription Drug Affordability Board. So it's really hard to fight the forces of pharma and the PBMs on the federal level and the state level.
Sure, and yeah, go ahead, Noam. Yeah.
No, I was just the only thing I was gonna add, because I think you're totally right, that I think people lose sight of the fact, we were talking earlier about the federal programs and the budget pressure that's on Medicare and Medicaid. But if you compare what's happened with prices in Medicare and Medicaid compared to what's happened in the commercial market, it's really a tale of two different systems. So, I mean, underlying, as Lucy mentioned, our problem is price. There's a professor from our alma mater, Louis Reinhardt, who used to say, it's the price is stupid. And it is. If you look at the per unit cost of Humira, of an X-ray, of bypass surgery in the United States compared to what exactly the same procedure or exactly the same drug costs in the UK or Germany or Japan, it's 3x, 5x, 10x here. It's just the price that our system charges is higher. And that trickles through. There are all these other problems that are associated with that and markets being gamed and what have you. But back to sort of what are the public programs do, if you look at the rise in the cost of Medicare and Medicaid on a per enrollee basis, it's actually pretty good. It would be pretty sustainable. It's been pretty close to what inflation is. Medicaid pays very low, and there are problems with that. But if you look over in the commercial market, like where we get our insurance, Blue Cross Blue Shield, United, what have you, the commercial market has essentially completely failed to control the price. So, you know, if you go, I don't know if there's anyone here from Dartmouth, and I don't know if this is a true example, but let's say for the sake, if you go to Dartmouth and you get your knee replaced there and you have Medicare, it's going to be one cost, right? But if you go there and you have Aetna, it's going to be 4 or 5 times the price. Nobody else does it that way.
I just want to ask you this question, and Lucy, you too. What we often hear when you make that comparison of, you know, one person with public insurance and another person with private insurance, it's often said, and I wonder what both of you think, that, you know, those Medicare and Medicaid, the reimbursement rates are so low that the private companies have to jack up their prices to cover the low government reimbursement rates. So you're sort of squeezing the balloon on one end, and that's why they say their prices, the commercial prices, are so much higher than what you pay for Medicare and Medicaid. And I'd love to hear from both of you on that. But Lucy, do you want to go first on that?
You know, I think
is there any validity to that argument?
It's a little bit of a simplistic view of it. I think there's been some effort to counteract that. It's really some of why it's so expensive is Medicare has incentivized that kind of structure, and there's really no counterweight. So one of the issues is we've had a lot of consolidation in our delivery system. So a lot of consolidation both vertically and horizontally. And we know that consolidation and hospital consolidation raises prices.
And we're seeing a lot of that in New
costs,
Hampshire.
And we've seen a lot of that in New Hampshire. And we, you know, have this funny, we love our hospitals and we love our healthcare providers, and we want them to survive. But simultaneously, that means we may happily sell a hospital to one who is charging 400% of Medicare for its prices. And we're thrilled, because that means it's surviving. So
it means it won't be closed down.
It won't be closed down. And so, you know, I think one of the problems is that you know, we've talked about this before, when there's so much stress, because people are under stress, as I said before, in all kinds of ways financially now. And healthcare is just, it's the icing on the cake. And if you go, I'll just add this one story, you know, if you look at employee programs where you can go for help with your employer, oftentimes the thing that is causing the most stress and real mental health issues are the financial issues, and oftentimes it's a medical debt, right? It's that last thing that is putting them over the edge that sends them to the employee assistance program and for mental health supports, because it's just so stressful.
Wow.
But, you know, we have just not gotten our hands around exactly how to manage it, and the payers are trying. They have sort of difficult tools in a state like New Hampshire, so you're seeing the prior authorizations that are making everyone completely crazy, and all kinds of other tools to try and reduce cost. Meanwhile, the systems are really focused on, to survive, on higher margin care. I think everybody would appreciate a level playing field and some way to reward real investment in primary care and to figure out how to make that happen and make it viable and not have to be in this arms race, but we're just building up and up and up. And the patient is sort of the last one to solve this problem.
What does that
and
mean,
they
Lucy,
end
like
up-
an arms race? That's an interesting analogy. Is it just like spending more and more on better and better technology, or?
Well, it's how
Yeah.
do you survive? How do you make sure you can employ the workforce and bring in the physicians and do your job for patients on your inpatient or your specialty care? You're going to want to make sure you have the patients. And so, we think there's actual free market. It's not a free market. It's hard to survive as a health system and in the healthcare space. But oftentimes, the way you survive is duplicating expensive services, and that doesn't get us where we need to be.
No, not at all. Noam, did you want to talk at all about that sort of squeezing of the balloon analogy? And then we're going to go to your questions, so get them ready, especially Lucy's students.
I mean, I guess I'll just say a couple things real quickly. I mean, one is there has been some attempt to look at, it's called the cost shift, whether or not providers shift costs based on how much payers are paying. And the evidence has sort of shown that it's not really there. But if you go and talk to people who work in hospitals, they will tell you they think about this nonstop. So I think there's a little bit of a disconnect between kind of what the academic research has showed and what the sort of real life experience of people who are balancing the books in these hospitals. I mean, I think though that the big picture is that, as Lucy was alluding, we have a system that is so complicated that it creates this incredible, almost every transaction in our healthcare system is an opportunity for someone to sort of arbitrage, because PBMs are doing this by their negotiation with drug companies. Hospitals are doing this with shifting around who they get paid for. And yes, the patient is the one left holding the bag, because at the end of the day, if something's not paid for, it ends up in the patient's lap. So, I mean, I think the thing that has struck me more than anything else about kind of watching our dysfunction in our system and looking at the way other countries do it is that everybody else has figured out a way to kind of regulate the prices of medical care. I'm not talking about creating Medicare for all or a government system like in the UK necessarily. Many countries do it differently. But they've managed to sort of create a more regulated system, because healthcare is viewed differently in those societies than, buying a car or a television. And we sort of haven't gotten there yet. I think we're getting there, because I think people are so fed up, and we can talk a little bit about that later if you want. But our system's so complicated, and we don't have any way of really controlling what these actors are doing. And so it sort of purports to be a market, but it's not really a market.
So, yeah, go ahead, Lucy, yeah.
So I just wanted to not leave out our business community, who is also suffering from premiums that go up year after year. And, if you look at the pressure on businesses because of our employer-sponsored, arrangement we have on how we get insurance if we're not eligible for Medicaid as someone with low income or in a category, or Medicare, then you end up having to raise your premiums every year by huge amounts, and that means you're not paying wages, right? So our benefits are part of our compensation. They are tax-free, so they are subsidized by the federal government. But if year after year you're having to chase the premium cost, then you're not being able to compensate your employees with higher wages. So you've got that added burden, and the employers have a real Hobbesian choice. Do you put more of the cost on the employee or not? And so, I think I go to some big meetings with employers that are national employers, and they say, we don't have the power ourselves to combat this problem. Even us all together aren't powerful enough. We want primary care, we want reinvestment in primary care, we want lower drug costs, we want patient-centered solutions, we want some flexibility in how we structure our benefits, and we can't get there ourselves. And so one of the questions is, everybody wants to make this work, how are we going to do that?
Right.
And right now, with some of the proposals coming in and some of the sort of wrecking ball strategy that's happening at the federal level, we're back to what happens in New Hampshire often is we're trying to oppose the bad ideas as opposed to go after the good ideas, and that is just exhausting and frustrating.
Yeah, instead of spending time on innovation and new ideas. I have so many more questions for the two of you, but I want to share you with the audience. So if you could just please raise your hand, and Anna Brown, our Executive Director at the Rudman Center, will come around with the microphone. Let Anna hold on to the mic, please, for audio purposes. Also, if you're joining us on Zoom, the Q&A function at the bottom of the screen is where you can put your questions. So don't be shy. We have two great guests, and we'd love to hear from you. So we have a question here and here. So Anna, why don't we go here first? And she will make her way to you. Everyone will become very good friends.
Hi, thank you for being here. And my question basically is, you talked about how in the United States this is a problem because we look at healthcare from a very different vantage point. Do you believe that relates to the fact that since we're such a high capitalist society and the fact that money makes the world go around basically here, that's the reason why we have higher health cares, we have higher health rates. Generics and drugs could end up being more expensive because more sadly it's more profitable to have people still dealing with a disease than working on treating them and making sure they're better so they don't require these things anymore, and how you think we can rise above that basically.
That is such a good question, and when Noam said what he said, that's exactly what I was thinking too, so thank you. Yeah, I mean, you said we sort of regard healthcare as like buying a TV or buying a car, and in other countries it's a little bit different mentality. Can you talk a little bit more about that? And again, thank you so much.
Sure, yeah, thanks for the question. Yeah, I mean, I think we've always seen it as a privilege, not a right. And that's a fundamental difference in the way that I think we as a society have approached it. I think there are a number of different reasons for it. Yes, I think we're a more market-driven ethos to the country. I think race, frankly, has a lot to do with it. One of the reasons why we don't have universal health insurance is because there was a time in this country when white people didn't want to have the same programs as black people, and that was a major barrier. And but I think things are changing, and that's one of the reasons why I feel somewhat hopeful, because I think people have finally realized that it's not working for anybody. And it used to work for enough of the people, enough of the time, that the risk of shaking it up was not tolerable for the majority of Americans. And so we would have piecemeal reforms like Medicare and Medicaid, right? We're covering this little portion of the population and this little portion of the population. And the Affordable Care Act was this sort of Rube Goldberg machine that was sort of patching a little bit of the system here and patching it there because, God forbid, we would shake this system. I think people are finally getting to the point where they don't feel like it works anymore. And maybe this is an opportunity for some rationalization.
Well, and Lucy, I was listening to the two of you talk, and just about how people are frustrated, individuals and the debt and the businesses and so forth. And I was thinking, okay, this system must be working for someone. When Americans focus their anger about the healthcare system, who do they focus on? Who do they blame? And how much is that focus misplaced, and how much is it on target?
We love to blame, and someone told me I had to be positive, so I'm not going to get into the blame game.
I didn't tell you you need to be
positive.
positive.
A lot that goes around. And I think that's exactly right. We would just so love healthcare to be competitive and a free market and capitalistic, and it's just not. We spend a lot in healthcare, so there are a lot of vested interests in the healthcare system that have got to come to the table if we are ever going to put our arms around cost, because it's not a free market at all. And the difference with other countries where the buy-in from the beginning is that it is a right, and it's something that everybody is going to contribute to and agree to regulate. We do it halfway here, and it doesn't work for anybody. And I think, I do think we have amazing healthcare providers. I think we have wonderful innovation. I think we have life-saving cures. You know, I think we have a lot of people doing a lot of good in this system. You know, we rolled out substance use treatment, and we have incredible mental health providers, but we just, you know, we can't get our arms around it when it's so bifurcated with Medicaid here and Medicare there and a million different private insurance companies. I mean, the carriers, I know everyone loves to blame the poor carriers. But, you know, they don't have amongst them, with the competition they have, enough lives to be able to really do value-based care with one, you know, in one segment and really make a difference. So they're constantly dealing with people coming and going, and part of the market share. So there's some economics that really make it difficult for payers as well, even though, you know, we love to take a piece out of their hide.
When you say
frequently.
carriers, you mean the insurance
I mean the
companies?
insurance companies.
Sure.
So it really, I would have to say that our belief that it can be capitalistic, and our continuing to bang our head against that wall is going to be, ultimately defeat us. And, you know, you look at the history, and it's true, we created Medicaid and segregated out the people who were getting this insurance because they couldn't afford it, and it created this absolute bias in the way we manage Medicaid, as compared to this belief that commercial insurance is for the worthy workers. And the subsidy that we offer employers for health insurance is, you know, every once in a while, it's a good, almost as much as we spend on Medicare from the federal government's point of view. So I do think that there were times in history when, right after the war, when we had a number of different proposals to make our system more cohesive, but they have continuously failed.
We had a question right here. Hi, Don, yeah.
Hello. As I think Mike, here, I'll come out here into the
There we go.
Hi, Don.
So as my friend Professor Hodder knows, I'm obsessed with the bloated and obscenely high cost of prescription medications. And that really is a function of the fact that my daughter, who's on my state employee health plan, had a pharmacy bill last year of more than $400,000, which is outrageously high.
Just for the pharmacy, Don.
Yes, just for the pharmacy.
Oh, my
And so,
goodness.
but I think my question is really for Mr. Levy, and it is this. Like all the law students in the room, I believe in the aphorism of Louis Brandeis that sunshine is the best disinfectant. And it really bugs me, and nobody's ever been able to explain it to me, why I can't go online somewhere and find out what the prices of all these drugs are. After all, these manufacturers have a monopoly on these drugs. I persecute public utilities for a living by day. You can go on the web and find out to a 1/100th of a cent what Eversource is charging all of us for electricity. But try to go on the web and figure out what the ultra-expensive cystic fibrosis drug Trikafta costs. You can't do it. I want to know why that is and what we can do about it.
Thank you so much for the question. Did you want Noam to answer that, or Lucy, or?
Well, either, but I was really curious about what the
Sure.
Well, as a journalist, I too am a big fan of Justice Brandeis's affection for sunshine. And believe me, I wish we could find all that stuff out as well. As for why we can't do it, it is because we have crafted a market in which we've essentially empowered, in this case, pharmacy benefit managers, with the job of negotiating on our behalf to secure drugs for us. And because we believed as a society that this was a market that would benefit us, we don't have any visibility on that. Now, is there a market there? No, of course not. We could spend the entire time talking about this particular part of the healthcare system, the pharmacy benefit manager. But I mean, I actually think there's few better examples of sort of the problem with all the rent-seeking behavior within our healthcare system than the middleman that is handling negotiation of drug prices in this country. Because if you look at the history of PBMs, So PBM started out basically in the 60s and 70s because there were newer and more expensive drugs. It seemed like somebody should be there to not only sort of process claims when you went to the pharmacy, but also presumably try to negotiate a better price. You know what happened then? The drug companies got wise to this, and the drug companies bought all these PBMs, which you might think, oh, well, how did that ever come to happen? And why was that allowed to happen? Essentially selling the negotiator, and if you look at Pfizer and Lilly, they bought all these PBMs. And then it turned out that wasn't such a good deal because it was obviously a huge conflict. And so they divested themselves of it. And then who bought them? Well, then the payers bought them. So now like CVS, Aetna owns a big PBM, and United Healthcare has its own PBM. But within that, they've kept this secret system of negotiating these prices, dealing with rebates, who gets the discounts. We can't get it. So to answer your question, how do we get to the end of this? I mean, talk to the folks in Washington.
Another question. I'm going to go back and forth with my questions. Student, member of the public, student, member of the public. So students. Any other students with questions? Ah, great. Okay. You're getting your steps in today, Anna. And I will try to go back and forth between students and members of the public. So this is fantastic. I'm so happy that so many of you came out tonight. We know it's a busy time of year.
Meet you in the middle. I'm gonna fall over. I'm a klutz. So, what about like hidden costs and stuff? Like, for example, when I lived down south, something that I found Tennessee did was for women-specific health issues. During diagnosis, I didn't have to pay a dime out of pocket, but they didn't make a clear demarcation of what counts as officially diagnosed and what doesn't. So all of a sudden, I'm getting these bills when I'm still going through what I thought was standard testing procedure, and I've now racked up this giant bill. I'm by myself. I don't know anything about medical testing, and so these hidden fees are also, I guess maybe they're not hidden, maybe I just didn't read the fine print, but the hidden fees of the medical system and how that's affecting us. And I guess I'd open that to anyone.
No, and that's a great question. And don't blame yourself, because I know very, very, very smart people who misunderstood a tiny, tiny word on page 36, and all of a sudden they're stuck with medical debt. So I'm sure you're not alone. Lucy, go ahead, please.
Well, so I have no perfect answer for you. We at least have in the Affordable Care Act covered preventative care, and oftentimes certain diagnostic and preventative care is covered. You have to read your health plan very carefully. It's very complicated. Oftentimes the providers don't even know. And so there's been a whole effort to try and enhance transparency. But as we say in our work, transparency alone isn't good enough. You need translation and transparency. You need engaged transparency. That's why we are trying in New Hampshire. We have incredible people providing information and translating our budget information, the Healthcare Consumer Protection Commission now, the Prescription Drug Affordability Board. We're trying to get translated information. We also have navigators who can help translate what insurance it covers and why, but you're often stuck not knowing, because right there and then you have no idea whether the next test that's been ordered is a test that's going to land in your pocketbook. And it's hard to know who to blame, but let's not blame, let's just figure out solutions for it. And I have to say it's hard when we look at some of what's going on, and every time there's real transparency and real explanation, anyone who doesn't like what's being revealed tries to shut it down. And it's really hard to combat that. And we're seeing that. I mean, look at all the employees just today, more employees being eliminated from all the federal agencies who provide us information. It's going to be difficult for us to navigate this as we have this effort in Washington to claim to eliminate waste, and I'm riffing on your question, way beyond your question, riffing on waste and fraud when that's really an excuse for arbitrary cuts. every system has waste. We examine the waste in healthcare, commercial, Medicare, Medicaid, every year to see what unnecessary payments are made. And we have it down to below 5% in Medicaid across the board and 6% Medicare. And what most of the unnecessary payments that they investigate are because there's not enough documentation. So to say there's billions of dollars of waste is hard to pinpoint. To be honest, a lot of the waste we see is the waste we've created in our delivery system that we really need to work to change.
Okay, I might pick up on that because that's an interesting point too. But question over here, hey, AJ, yeah. Like I said, I'm trying to go back and forth between students and members of the public. So good job, everybody.
So I'm with the New Hampshire Insurance Department. We just recently released our total healthcare expenditure model. Thank you for bringing that up. nhhealthcost.org if you want to see that. But we released our New Hampshire health cost dollar. 52% of the money spent on healthcare in 2022, it's the first year that we're releasing the data for that, is just on facility fees. Inpatient, outpatient, 20% is prescription costs, for example. That does not include the doctor, the nurse, any of those people's 52%. I was wondering if you guys could address that being such a huge piece of the pie.
Sure. No, AJ, and thank you. And just tell us real quick, what's a facility fee? Just so everybody's clear on what that is.
Actually, could you talk about that?
Well, it's a practice that hospitals have initiated when they buy up a physician group. Instead of paying the physician fee simply, the consumer ends up paying a physician fee and a separate facility fee.
I see. So I live in Concord, so a lot of the small doctors' practices in town have been bought up by Concord Hospital, so it's the facility fee. Okay, thank you so much. It's good to have people from the Department of Insurance here. Wow.
Well, so first of all, thank you for that statistic. I mean, I know facility fees are hugely problematic, but that's a shocking statistic, actually, that it's that high. A couple of things to say. Number one, prescription drugs get a lot of attention, rightfully so, because there's some very expensive, high-cost drugs. But the driving cost for the American healthcare system is hospital care. And hospital care used to be confined to, you went down to Boston, you went to Mass General, and then you were a hospital, right? But because over the last 10 to 15 years, health systems have not only consolidated in terms of having multiple healthcare hospitals that are owned, but they've bought up independent primary care doctors, independent cardiologists, it's increasingly hard to find an independent physician. And hospitals used to attach what's called the facility fee to the bill that you got if you went to the emergency room or you went for an inpatient procedure like like you had an appendectomy or a cancer surgery. And the argument was, hospital is a community institution. It's open 24 hours a day. We got to staff the emergency room.
It's always here for you.
It's always here.
Right.
You need to have this extra fee. Now, the things that hospitals started doing was attaching this fee to each of their outpatient bills. So if you went and saw Dr. Smith, who was just bought by Dartmouth-Hitchcock, even though he was still practicing, 50 miles from the medical center, they're attaching a facility fee onto that. And it's hugely inflationary. There have been efforts, and I think they'll ultimately be successful, actually, in Washington to crack down on this practice. But I think more than anything, they illuminate the underlying problem with hospital care in the United States, which is the sunken costs in these incredible health systems that have been built around the country are enormous. And if these places are magnificent, right? I haven't been to Dartmouth-Hitchcock, but like my dad used to practice at one of the medical centers down in Boston. I remember going to visit him. He was at Boston Children's, 35, 40 years ago, and you went there, and the place hadn't basically changed in 40, 50 years, and the people were lined up outside on the benches waiting to go in. You go to those places now, you go to Mass General, you go anywhere. You probably go to the HCA hospital down the street here, and these places have, marble lobbies, and they have water features, and, the lighting is incredible. Well, someone has to pay for that, and ultimately our system is supporting incredibly expensive. We like it, You know, if you spend time in a hospital, you go to a hospital in the NHS in London, like, none of us would probably want to go there. Because they don't look nearly as nice as ours. But, you know, nobody goes into debt there either, so.
Yeah, pick your poison.
Anyway, sorry, that's a
I'm
long
so
answer.
glad you raised that. And actually, Lucy, this raises your specialty, which is hospital consolidation. So can you talk a little bit about how hospital consolidation here in New Hampshire has also increased costs?
Yeah, it's a very compelling, sad, and also where are we going story, because each one of these consolidations has really good reasons for it happening. And our communities really do love our hospitals. They're big employers. We want them to survive. We really want them to be there to deliver our children. We want them to be up in the North Country so that we can raise a family up there. And, you know, the tradition in New Hampshire was each one had its own monopoly. But the infrastructure and bringing in the specialty care, you start competing for that high-end specialty care because it's getting more and more expensive, and we have more and more life-saving innovations and ability to do it, and it just becomes so expensive. And, you know, then they're on the brink of failure, and then there's someone who marches in and saves them. And we've had almost all of our hospitals consolidate, some because they're failing, some just because, you know, Massachusetts has wanted to come up here. And they all have a slightly different story, but the end result is very little collaboration. We had a certificate of need board. God knows it wasn't perfect, but it did at least track new expenditures and new services. Now we have absolutely nothing. Unless you've gone through a merger and the Attorney General's office has been able to put a condition on your hospital, we have absolutely no regulation of whether a service exists or not, or how much it costs, whether it disappears, comes, goes, disappears, moves out, off, outpatient, whatever. There's absolutely nothing that oversees that process. We have, I think, 1.5 people who work in facility licensure in the state of New Hampshire. You know, that's about it. And they do a wonderful job, but they mostly do Medicare certifications, not real licensure review. So we just don't have a plan. And why would you as a hospital decide to stop building your, you know, profitable specialty services, especially because you have so many sick people coming in? Why would you stop and say, oh no, we want to divest from that and go into primary care and mental health and substance use, which is really what our community needs, and address the social determinants of health and public health, because by the way, we're losing, you know, people aren't getting vaccinated anymore. So let's look at what we do in the community. In order to make that decision, you might forego your ability to continue as a hospital. And so, you know, we really do need to sit around the table and figure out how are we going to plan for this going forward. And I don't mean to be glib about vaccines, but our legislature is getting rid of our vaccine board. So our state legislature, so it's high on our list of concerns. So it really is this combination of, it's not the hospital's fault that it's built up this way. It's partly capitalism, it's partly because it's been possible, but we don't have a way to remedy the problem rationally or collaboratively, unless we really work at it.
Well, and in a few minutes, I will ask both of you about possible solutions if we could all kind of sit down together and figure it out. So we won't just talk about the problem, we will also talk about solutions. So I want to go to a student next. So I see someone over there. So Anna, again, you're working for it today.
Actually, I did not choose the student for it. Thank you. So I kind of want to go back to prescription negotiation and bring it to a state level. I know that states do have some tools to kind of help negotiate with pharmaceutical companies, although it's very limited. And so I go back to California, where they do have this like CalRx, and where they are working on their state branding insulin. What are your thoughts, especially Professor Lucy, about how that could work in lowering prices? Would federal government allow it? And yeah, that's kind of like what I just would like to know.
That's such a great question, and it's a really interesting one. California is doing something fascinating, which is they were so sick of the fact that insulin, which is very available and should be, has been so expensive, and there's so many people in this country with diabetes, and you can't get insulin. And if you ever get it affordably, you're not going to be able to get the supplies that go with it. So it is just the number one reason why you could say our system is not working for the people who need it, because God forbid you have diabetes and are on insulin and you're trying to buy it. And California just got sick of dealing with it and all the patent wars that were going on, and the changes in modalities that increase the protection, and they basically said, we're going to manufacture it ourselves. And so they're trying to manufacture it themselves. I don't know how successful they're being. Somebody here may know more than I know. But with regard to New Hampshire, we haven't made a lot of progress. There are a number of different bills. I think it's really important to remember that our insurance department regulates only some of the employer-sponsored insurance that we have. Because of federal law that regulates through ERISA our health benefit plans. If they're self-funded, basically the state is preempted from regulating them. So the state can only regulate fully insured. So we don't have a lot of tools. We do have this Prescription Drug Affordability Board, but it's just looking at our public health plans. And it is under assault, but does a great job. I will also say that, there are constantly questions about what we can do or not. There was a bill to have the state allow for purchase of drugs from Canada. Maybe if Canada becomes a state, that will be easier.
Problem solved.
That didn't work very well. We really need help from the federal government around prescriptions because of the fact that we've got the FDA with exclusivities, and we've got patent law, and we really do need help, and we just haven't gotten it. Again, I reiterate, there was a bipartisan bill to bring some transparency around PBMs and do a number of other things, and it keeps getting eliminated from the budget packages. So we don't have that kind of a solution in New Hampshire, not for lack of trying, and hopefully those efforts will continue.
Well, I'm so glad you asked the question, because one thing I wanted to ask you, Noam, is what ideas have come out of individual states, California, maybe New Hampshire, that tackle affordability? I mean, states are often called laboratories for experimentation. So what have you seen at the state level that might make an impact in these costs that we're talking about?
So there have been some interesting efforts, and I guess I would sort of divide them into a couple of different baskets. I mean, so we talked a little bit earlier about the problem of medical debt, which obviously is sort of the very end of the process, right? I mean, it's the ultimate evidence of a system breakdown. And there have been efforts by states to sort of ameliorate the worst problems associated with patients going into debt. So for example, some states have put limits on, you've probably read stories about hospitals suing patients or putting liens on their homes or garnishing their wages. States have begun to sort of limit this kind of, I think, difficult to defend behavior by medical providers, to stop medical bills from being reported on people's credit scores. So that's sort of one basket of interventions. The Biden administration was beginning to do some of that stuff through the Consumer Financial Protection Bureau. As you may have read, the current crop of folks down in D.C. have basically locked the doors to CFPB and nobody's working there anymore. So we don't know what's going to happen at the federal level. The other thing, in some ways, which is more, I think, promising, and which gets at, more underlying causes of patients' stress, is trying to attack the way that health insurance is designed. So, ultimately the reason why people are going into debt is because they have health insurance that requires them to pay thousands of dollars out of pocket before their coverage kicks in, right? I mean, it's not a really complicated explanation. You have a $5,000 deductible health plan, you have $500 in the bank, you can't go to the ER with a hangnail and get out for less than $2,000 or $3,000, you're going to end up in debt. So California, New Mexico, a few other states have begun experimenting with the plans that they offer on their marketplaces through the Affordable Care Act. So this is, for people who don't get coverage through an employer, they go to the marketplace and they get it, to try to exempt some services from deductibles, particularly primary care. The notion being that if you reduce the barrier between the patient going to the doctor for basic primary care, they're more likely to get treated for smaller things that maybe
You save money down the
save
road.
money.
Yeah.
And those have been,
yeah. Oh, sorry.
those
Yeah.
have been promising, I think.
Other state innovations, Lucy, that you want to talk about?
Well, you can either have your health plan be creative and value-based, and if you have enough people in it and you are working with a good vendor as an employer who's self-funded, you can do some things to try and help steer your patients, help your employees, support them with employee assistance, and also a value-based structure. So there are ways to do that. We can also change our payment model and payment models. And again, trying to put several steps forward. We just heard yesterday that a number of the primary care innovative models that we were testing for payment were just eliminated at the federal level. So again, it's one step forward, 3 steps back on this. But states can do some innovative things with allowing for group purchasing and also in purchasing with information that's available. You can create plans where you basically take the lowest price of what's available. So if there are 7 different costs for MRI, if you do reference pricing, you can pick an average price. You can set up a plan that just takes the average price. And that's one thing to do. It's also really important, again, some of the little things really do matter, so that if we have the data so that we can figure out what some solutions are, and we can also have navigators and consumer protection support for people so we understand what their needs are and how they can tackle some of the tough questions. We really need to get a plan around our delivery system and how we want to manage it. What do we want to spend our $13 billion on? And figure that out. I think there's some great ideas in prescription drug reform, transparent PBM pricing, and also other ways to eliminate the burden on the actual patient at the pharmacy, and also eliminate that site of service differential. So when you have infused drugs, you're not paying a gazillion dollars because you're doing it in a place you don't need to. You can do it outpatient. We have some innovative ways to bundle care that's more affordable. So there are a lot of things to do. We just don't have a real place to sit down and make them happen.
I mean, is it possible to do that at the state level, or is that really action that needs to happen at the federal level? Lucy, what do you think?
Well, I think a lot of that has to happen at the provider and payer
Gotcha.
and employer level
Right.
for who's paying for the care. I can't leave here without also saying it's helpful for us to try and think about the solutions. We know with the levels of, we know the pandemic was 5 years ago, and we know just what that's done and what the impacts on our health and our mental health to our community. And when you look at our lack of spending on primary care, it's only worse when you look at our lack of real spending on mental health care in the commercial population in terms of trying to bring supports, despite the fact that we have a law that says you have to spend the same amount. And a good portion of our inpatients have a corresponding mental health issue, and we just, it's been a frustrating effort to try and get that to be paid for. But one of the things is hard is when you see things that are clearly going to hurt our health care and our costs going on, and we wonder about how to address them. So, for example, taking away access to health care for, we are all, have reproductive organs, no matter who you are, and not having access to full spectrum of reproductive health care is causing death, it's causing infant mortality, maternal mortality, it's causing having a huge impact on our system. That didn't need to happen. And, you also see things about vaccines, and vaccines provide life-saving protection to our families and our children, and making it more difficult to access affordable vaccines is going to impact our health care and our health costs. So some of the things we see happening that we know are intuitively based on the science and the data and the medicine just going to make it harder are incredibly frustrating. At the same time, I look at the people in the room, and I feel like there's probably the expertise to solve most of the problems right in this room. And I have more faith in all of you than I do in what goes on outside. So I think there really does need to be serious conversation, and this is when New Hampshire tends to get going, when the headwinds are really strong. So.
Well, and we can share ideas at the reception afterwards, so don't forget about that. I think we have a question from our Zoom audience. So Redmond Center Coordinator Ellen Grimm is reading questions from our Zoom audience. So go ahead, please.
This is from Carl. It says, how do you see the new trend from mid-levels, that is, nurse practitioners, physicians' assistants, shaking out in terms of cost reduction? It seems to be a promising opportunity.
Oh, yeah, that's a good question. Either of you know the fact that, most of the time when you go to see the doctor, you end up seeing the nurse practitioner, which most of the time is fine. And that's allegedly to save money, but what do you think, Noam?
I mean, yes, I think there's been some evidence that it can be a lower cost alternative. It's frequently more a function of necessity because there are not enough primary care physicians. But unfortunately, I think it's like a Band-Aid compared to some of these other problems that we've been talking about. I mean, even trying to figure out a model that sustains primary care particularly, I don't think that's going to be the solution.
Lucy, you mentioned people need to get together, people need to talk about this, there's a lot of data, there's a lot of ideas. Noam, KFF News recently polled Trump voters about where they place the blame for high costs and what they want the president and the new administration to do about it. So what did you find?
So to be clear, we didn't poll.
You didn't poll.
We did not poll.
You reported on the
some
polling.
Other polling that was done. But one of the polls that was most interesting to us, or to me, I guess, was one that was done by Fabrizio Ward, which is the polling firm that worked for the Trump campaign. And Tony Fabrizio was the pollster for the Trump campaign. His business partner did this polling. And one of the things they asked was Trump voters and others kind of what kinds of policy interventions they would like to see. And I think the thing that really stood out was how ready many of these voters are for very robust government interventions. Things like regulating how much hospitals can charge, regulating how much drug companies can charge, and that there's obviously historically been this conception that Republicans and conservatives are more leery of the government stepping into the market. But I think this polling, and there's some other polling shows this as well, suggests that Trump voters, like everybody else, are fed up and are ready to have somebody come in, and they don't view the healthcare market like the auto market. And they don't want the government to tell you to buy an electric car, but they might be okay with the government coming in and saying, hospital X, you cannot charge more than this for your x-ray or your knee replacement.
Well, given the extensive amount of medical debt that you described at the beginning, some of those people,
It's bipartisan.
everybody has medical debt, so
bipartisan.
it's a bipartisan
It's a
problem,
bipartisan problem.
for sure. Lucy, did you want to weigh in there at all?
I think the problem is our solutions are going to hurt, and therefore it is easy to blame and push the blame off somewhere else and push it off to a long-term solution, because we really look at things short-term. We like problems that can be solved tomorrow. And I think one of the really important issues is to figure out how to build the trust in this world of misinformation, where we, again, don't even trust basic public health data. And in fact, CDC data is being taken down from the websites, and WHO is no longer something that we're respecting. And it's really hard to figure out how to build the trust and trust the information so that we can decide what type of regulation, what kind of system are we willing to go to. Because we've spent a lot of years being really happy with the fact that we've got the best cancer care in our neighborhood. We've got the best doctors. We've got, and to answer your question, I think the developments in New Hampshire to train nurse practitioners and nurses and PAs is phenomenal. Everybody, it doesn't take the place of primary care, but it certainly is a really important and necessary part of our healthcare delivery system. And boy, good nurse has saved my life. So
Yeah. Well,
I just think that we really have to build out from a core, hearing the people and the patients. It's oftentimes you get blamed for calling out what's going on, and this is what patients are experiencing. This is what employees are experiencing and employers. And we're going to get some waves of hurt from Washington, because I don't know that there's a real plan around how they want to make healthcare more affordable. And we're going to have to, in New Hampshire, really figure out what we're going to do as a result, because I think more people than not want there to be someone minding the store.
right, so we the people need to start squawking if we're upset about it. You've been trying to ask a question for a long time, so I'm going to make Anna walk over, and we'll take one or two more questions, and then we have to close out, but we do have a lovely reception with hearty hors d'oeuvres for you downstairs, so we can also talk more down there, but thank you very much.
Hi,
Thank you.
Travis.
Thank you. Hi. It's good to be here. I'm Travis Harker. I'm a family doctor. I'm Tufts Medical School faculty in Portsmouth, at Portsmouth Regional Hospital. We started programs in family medicine, internal medicine, and psychiatry to help meet the workforce needs. There's been a lot of talk about the importance of primary care here. I think an unfortunate kind of side effect from the Affordable Care Act has been pouring gas on the fire of consolidation. In order to make money under value-based care, health systems need to continue to grow bigger and bigger and bigger. And so that, I think, is a driving factor for the consolidation that's concerning, as well as the cost increases. I know as a primary care doc, I try to take care of my patients, many of whom are really happy with the care that I give, but there's some, especially as we get closer and closer to Boston, feel like they need a specialist for every organ system, whether they need it or not. And so I'm wondering if there are any policy plans or ideas that would actually help shift the balance back towards primary care. I know the American Academy of Family Physicians says we should spend 15% of our healthcare spending on primary care. We're a far cry from that. I think we spend about 5% now. And we're building the workforce, we're working on it. But how do we get people, the public, to start changing their minds on, like, I can get exceptional care with primary care. Primary care will refer out when I'm needed, but I don't need a specialist for every little thing I have.
Yeah, I think that's a really important conversation, and I know there's some specialists in the room who would love to have primary care handle more of those cases. And so I think you're exactly right, which is, how do you get back to that world where primary care is substantial enough, reimbursed well enough, and we shift it? Massachusetts actually has passed a couple different times bills to force a spend on primary care. We have just started, and the insurance department has just started to look at our primary care spend, and it's about 6%. So it's a really important question, and I do think it's going to take collaboration with hospital care, because oftentimes you don't get the testing, you don't get the follow-up, you don't get the discharge. That doesn't happen unless you're in the hospital, which just exacerbates that problem as well, where you have all that care in one place. So how do you get the care back to primary care and allow it to happen in that space with the ability to consult and be reimbursed for that? I think that's a really important question. That's what all the employers want. They want their employees to be able to access sort of enhanced primary care, where you can really get your issues met. So I'm sure some in the audience have solutions that I don't have.
Yeah, go ahead.
I just want to add, for whatever this is worth. I mean, take it for what it's worth. So as you probably know, the NASM, the National Academies, had a big primary care report a few years ago. And one of the things which the academies called for was a rethinking of primary care as a right. that primary care should be in some ways held up as something separate and on par with, say, public education. And I'm not a physician, obviously. But I'm a journalist, and from the perspective of communication, I wonder whether or not, I've spent a lot of time in primary care offices, in advanced primary care particularly, and watching patients go through that experience, it's like seeing like a light bulb has gone off in their head, that it can be something different. Someone is coordinating my care. Somebody is checking in on me. Somebody's even picking me up if I can't get there. Someone's making sure I fill my prescriptions. And that the public's expectation for what primary care ought to be, it seems to me, is misaligned with what actually primary care can be. But in the current system, and I don't know what the dynamics are for you in Tufts, but as long, it seems to me, as primary care continues to be part of a broader system that people are losing faith in, that it will be problematic to build a public case for primary care, and that some idea that can capture the public's imagination, something that is really special, and also really importantly, something that's free. And that I think ultimately is something that could potentially galvanize people's interest in having something special in primary care, whereas right now, as you well know, right, it's seen as the sort of stepchild that, most health systems don't really want to think about it, except in the sense of like as a feeder to get them to their higher cost, higher margin care, right?
Any other students with questions? Because I've been trying to go back and forth between student, public. And I think we have one or two students over here.
Hi, thank you both for being here today. So this is an issue that's huge and has a long-term solution, as you both mentioned, but what tangible steps can the audience take to start running this marathon towards a solution?
I love that question. Thank you so much. Yeah. Lucy?
I knew someone wonderful was going to ask that question, and I was going to have to figure out what on earth am I going to tell you. So I think this conversation is critical. I think we need to stop going backwards. So we need to get out there and advocate and share good information. I think we need to create a space where it is safe to talk about solutions without the vested interests feeling like they're going to get screwed tomorrow, because that's what tends to happen. Everyone puts their chits on the table, and then somehow what they used to have, they don't have anymore. And we've really got to get a space for that to happen. We have a couple opportunities in New Hampshire where we've, as a result of some of these hospital transactions, we've created the New Hampshire Healthcare Consumer Protection Commission, and we actually have the chair right here, and it's really looking at, okay, we've got these consolidations, what are the conditions, what are the impacts, what does our system look like, what are the key indicators we need to be tracking, and then how do we have the hard conversations? I look around the room at a lot of you who are in this field, and I know you're just desperately trying to hold on to some of the dollars that can keep your system going, and hold on to those relationships and hold on to those partnerships. We need to get ahead of that, so you aren't stuck with all of your voice having to protect what you have now, and we can actually think about what does a reasonable system look like in the future. And I think being active, attending the hearings, figuring out, how to get involved in actually speaking up as patients. We have the New Hampshire Healthcare Cost Commission, which is coming together to bring together voices of patients about this experience, and that in the handout, the actual website for the New Hampshire Health Cost Commission, the New Hampshire Healthcare Cost Initiative is on that handout. And so that's another place to get involved. We have New Futures, which is advocating for health policy and seeking stories. That's another place to get involved. And then, honestly, employers, the businesses need to come together and say enough. We've got to think about solutions on how we actually negotiate financial arrangements that work for us and our employees, and we come together to figure out how that works. Because some of this is advocacy and is about the patient, and then we've got the complicated issue of the financing of healthcare that we've really got to tackle.
Well, it's a fantastic question. I'd love your thoughts on that too, Noam. And then I feel so badly. I know so many more of you wanted to ask questions, but I have to close it out because I did promise to close it out by 7:15, and I know people have places to go and things to do, and students have studying to do. But Noam, I'd love your reflections too on that great question.
Yeah, it is a really good question. And I mean, it is very hard. We've been sitting here and God knows, like, I'm sure, Lucy, you've been participating in so many of these kinds of events over the years where we all like just pull our hair out and we think, oh my God, the system's never going to be solved. And we've just spent like an hour plus, right, going over all the problems. And I guess I would just say two things. One is, having covered the debate over the Affordable Care Act, I was saying earlier, obviously, the Affordable Care Act did not solve our problems. And in some cases, I think you're absolutely right. They exacerbated some of the problems. But also, the Affordable Care Act was a historic achievement. Mm-hmm. And I think it's easy to lose sight of the fact that in most states in America today, health care and health insurance is guaranteed, right? Medicaid has become a lifeline, like, for millions of people in this country, and so have the affordable care, the marketplaces. And that simply wasn't the case. I mean, now some of you are maybe too young to remember what it was like beforehand, but beforehand, people would lose their health insurance if they got sick, or if they didn't make enough money in most states in America, they couldn't get to the doctor. And so we shouldn't lose sight of the fact that major change has happened, not just in our lifetime, but just in the last 15 years. And that brings me to sort of where we are today. 6 weeks ago, people who cared about Medicaid in this country were running around with their hair on fire, thinking that this current administration and this Congress was going to gut that program and was going to take $1 trillion out of Medicaid and throw tens of millions of people literally onto the street. And in the course of just a few weeks, it's not over. The debate in Washington is still very much going on. But I would wager that Medicaid will survive this debate. There'll be some tinkering around the edges for sure, and probably not in the direction that most of you would feel comfortable going. But the program is secure in large part because an enormous number of people, politicians, doctors, patient advocates, and others rallied, and they told members of Congress, don't touch this program. And this program also it's become a political force in and of itself. And so that is all to say that it's because people were engaged and they cared about, in this case, Medicaid. You could apply this to many other things. But a program, Medicaid, which used to be viewed as like the bastard stepchild of the American healthcare system, it was welfare medicine, it was saved. And that means that like tens of millions of people are going to continue to have access to healthcare. And so I think it is possible to make change and to save. And unfortunately, I think at the moment, those of us who care about democracy and other things are a little bit on the defensive. But going forward, I would say that the clarion call should be protecting patients' financial security. And that for decades before the Affordable Care Act, the clarion call was people deserve to have health insurance. I think now the clarion call should be people deserve not to go bankrupt if they go to the hospital. And that from that mindset will stem a lot of the more complicated, extremely difficult blocking and tackling that's necessary to create the systems that will make that possible. But that if that's the North Star for people, that will catalyze a different kind of conversation, and maybe we'll get to something consequential.
And if you want to read more about it, if you want to read and learn more about medical debt and that sort of next step, as you mentioned, everybody who came, we sent out an email to you from the Rudman Center with some of Lucy's work and some of Noam's reporting on medical debt. It's pretty eye-opening, and I do recommend that you read it. We do have to close it out. Huge apologies to all of you who I did not get to. It's a wonderful problem to have as a moderator, which is to have a very engaged audience, so much so that you can't get to everyone. But we do have a reception downstairs that we invite you to. Before that, though, I do want to thank Lucy Hodder and Noam Levy for being here. Also to the audience, again, it's fantastic to see so many faces. I do need to invite Rudman Center Executive Director Anna Brown back up to the podium for a few closing remarks. So go ahead, Anna, who
More
got her steps in
housekeeping.
tonight.
So I would also like to say thank you to the Peter G. Peterson Foundation for their generous support for tonight's event and their ongoing work related to healthcare costs, but also the larger fiscal issues facing our country. I want to thank Concord TV for being here today. As Laura mentioned, there is a reception downstairs below. There is a snack table for students, but I promise the reception is more than just snacks, in case you see that. Also for students who are here for the Rudman Summer Fellowship opportunity, there is a sign-in sheet, so if you didn't get a chance to sign in that, I will leave that on the table here, and just please sign in before you hit the road. And with that, we conclude the event. Enjoy downstairs.
Thanks, everyone.